This is oxygenated on the left side, right? Yeah. And if it goes to the right side, because it's oxygenated already, they're not cyanotic. So this is the left to right shunting. So number 1 is left to right shunting. All of these 4. The number 2 is when the blood from the right side goes to the left side, which goes to the circulation already without going to the lungs. This will be your cyanotic. So this one is acyanotic. So this is number 1. This is number 2. Okay. When the blood moves from the left and goes back to the right, they are not cyanotic because it's already oxygenated. There are 4 disorders we're going to talk about. They're similar in nursing care. They're very easy. Okay. The other one is from the right goes to the left, meaning it's still deoxygenated and it went straight to the aorta and the system. It's not oxygenated yet, so they turn blue. There's only one we're going to talk about, the trilogy of Fallot. Okay? Fallot. All right, number 1. Atrial septal defect. So very easy. This is the atrium, and this is the septum. There's a hole. Okay? So the blood from the left will go now to the right. So this is your ASD. Now, if I do a VSD, where is the hole? The hole here is in the bottom.
So very easy to make a hole, I just erase it.
Erase it? It's gone. And then, so this is left to right again. They're both acyanotic, VSD. Now, do you remember our PDA in maternity when blood goes to the right side of the ventricle and then it goes to the lungs supposedly? Yeah. Right? And then from the right ventricle it goes to the aorta. Yeah. So now there's a hole in this too, like in maternity, right? So the blood from the right ventricle will go straight to the aorta. So there's a patent ductus arteriosus. PDA. This is the pulmonary artery. So that's a PDA. And the last one is coarctation of the aorta. Coarctation is just narrowing. So like narrowing. This is coarctation of the aorta. Narrowed. Okay, so all 4 will fall under acyanotics. Let's talk about them one by one. ASD briefly on page 607. There's a hole between the right and the left. Blood that contains oxygen is forced back to the left side. That's why I told you they are asymptomatic. I mean, they are not cyanotic, plus a lot of them are asymptomatic. But if there's ever one symptom that we hear, it's going to be a murmur. Murmur is any abnormal sound. So dab or S1, S2. Then it will be S3. So how do we check? We do cardiac cath. This is applicable to everybody. How do we close it? How do we solve it? Close it with a patch. It's a Dacron patch via surgery. That's not our job, so I don't really want to talk so much about it. Doctor will close it. It can also be done non-surgically during a cardiac cath. Sometimes it can be done. But otherwise, doctor will have to close it under it during surgery. So as nurses, our instruction in the bottom is to tell them this child will be on low-dose aspirin for about 6 months after the repair, and they usually get better and the prognosis is good. Simple. Same story with VSD. On the VSD, the hole is in the bottom. It's the most common of all the 4 there that I listed on the board. The most common heart anomaly is the VSD. There's an opening between the left and the right. Same story, it's just in the bottom. And in the middle of the paragraph, same story also, there's a murmur. Are you still seeing it? Murmur. And then, in the same paragraph, you would see that there's no treatment in small children. Maybe it will close by itself. Or it can be closed during cardiac catheterization. But nonetheless, if it doesn't close, on the right side of the book, you would see open heart surgery will be done under hypothermia. We lower their temperature so we can do the surgery with a bypass machine. The hole is closed or ligated with sutures and a patch. Same story. Yeah, so many words there, but it's actually the same. Where's VSD? All right, there. The next one is the patent ductus arteriosus, where they remain open after birth. It was supposed to close when the baby takes the first breath, right?
Oh, yeah.
So this remains open, and after birth, the lungs should be functional, but there's an increased pressure. So now the blood will go back to, what is this? The aorta shunts the blood back to the lungs due to the patent ductus arteriosus. So now they will still be oxygenated, right?
Yes.
So they will not be cyanotic. So do you remember our treatment for this? Endomethacin. Very good. So we're going to put there, you'd see in the bottom of page 609 in the paragraph of PDA, you see prostaglandin is one. To keep it patent until surgery, but to close it, we will give indomethacin. Okay, two possible questions. We want to keep it open, otherwise if you close it, then we can't do the surgery. I mean, the child will have difficulty with the circulation. So you will give prostaglandin E to maintain patency until the surgery can be performed, but to close it without surgery, we can give indomethacin. First paragraph, sorry, I missed this first paragraph. Right below the pulse pressure, you would see an unusually wide range. The systolic is wide from the diastolic. So that's a classic sign. So let me recap. Of the first, remember the first ASD, BSD? The main sign was a murmur, right?
Yes.
This PDA also has a murmur, louder murmur, machinery type. There's the description there, right on top of pulse pressure. But aside from the murmur, their blood pressure is also wide, the pulse pressure. Systolic is wide from the diastolic. Okay, so that's a classic sign of PDA. We need to close it with the indomethacin or surgically. The next procedure, the next disorder is coarctation of the aorta, wherein there is a narrowing of the aortic arch. So there is, same paragraph, 1, 2, 3, 4, 5, about 6 lines. The classic sign is a marked difference in the blood pressure in the upper and lower extremities. The coarctation could happen also here. You see this? This is the aorta, this is the blood. And so what goes to the body? Would it be less or more? So that's why if you look at the patient, the blood pressure in the lower part of the body is lower, and the blood pressure in the upper part, the head, the arms, the BP is high. The BP is low because the coarctation is here. There's not enough blood flow through the legs. So a classic sign of coarctation, COA, is right there, 6 line 7. Marked difference in BP in the upper and lower extremities. On the X-ray will show the narrowing. We will do a 2D echo also. The treatment is to anything that's narrowed, we do a rotor-rooter. We want to dilate it. That's the doctor's job, so I don't worry so much about it. Okay, then we go to the only cyanotic defect. Do you have an eraser?
Here.
Thank you. Thank you. So the only cyanotic is tetralogy of Fallot, which, if you look at it, is actually made of 4 disorders, right? Tetra. So it's 4. Every nursing student, I suppose, all the nurses out there, at some point in their careers, maybe they don't remember now anymore, but all nursing students should know what the 4 disorders are. So the first one is narrowing of the pulmonary artery. Here, this is the tetralogy of Fallot. The first one is the pulmonary artery was here, right? So it's narrowed. This part is narrowed. The second one is right ventricular hypertrophy. That's number 2. You would see in your book? Or they start with hypertrophy. Pulmonary arteries first, and then right ventricle. And then the third one is dextroposition, right? Dextroposition. We're in the aorta. Supposedly the aorta is coming from the left side, yeah?
Yes.
But in this case, it will be a little bit in the middle. So this is number 3. And then number 4 is a hole in the VSD. So number 4 is here. I know my picture is weird, but in my mind, I know how it looks like. But you can go to page 608. I don't like this picture, by the way, in 608 because they're square. And it doesn't really follow much. So in the bottom for tetralogy of Fallot only. Let's look at tetralogy of Fallot. The first disorder was the pulmonary, the one that goes to the lungs. The pulmonary stenosis, right? And the second one is the right ventricle enlarges. So that's the number 2. And the third one is the aorta is narrowed, or I mean, not narrowed, but in the wrong place. Dextroposition. And the fourth one is a VSD. So there are 4 disorders for tetralogy of Fallot. Because the blood has been mixing, you will see the patient turning blue. So on this side of the book, page 609, I'm going to go right below number 4. When the venous blood enters the aorta, the infant displays symptoms of cardiac problems and cyanosis increases with clubbing of the fingers. I'm still on the same page, 609, right on that paragraph. What will the heart do to compensate for lack of oxygen?
Pump faster.
Will beat faster, will pump faster, and will produce more RBCs.
Right.
That's why you would see polycythemia there to compensate for the lack of oxygen. Right, and the bottom paragraph, the pulmonary artery causes CH, it's narrowed, will cause CHF, and so therefore hypoxia. On the next page, sitting on the board exam, classic sign of tetralogy of Fallot is a TET spell. TET spell you will see because this child will be sitting like this, squatting position. It's the most comfortable position for them, knee chest. This occurs during a TET spell, and it relieves their SOB. Okay, let me say that in the playground. On the playground, you will see a child sitting like this, and when they sit like this, they get relief from their SOB. You would suspect it's tetralogy of Fallot. That's one possible question. When a child suddenly just squats like this and they stop playing with their playmates and they squat and they breathe easily after doing that, that's tetralogy of Fallot. It's a possible question. Another possible question is, if you're the nurse, how would you carry the child? Like this. Carry them on a position, on the TET spell position. Should be knee chest position. Third paragraph. Diagnosis is confirmed by an x-ray, and how the heart looks like is, remember which one is hyper here? The right ventricle, right? So when you look at the x-ray, it will look like a boot, boot, right-sided boot. A boot-sized heart. Because of that hypertrophy of the right ventricle. Sit there.
Yes.
Yeah, and then the next paragraph, you would see to compensate, the heart will produce more, or the body will produce more. So there's polycythemia. Yeah, then they will be anemic at some point. They could have endocarditis. The next paragraph, to treat this baby, there are 4 disorders. I can't just give meds. There's something there. There's a hole. There's narrowing. It's right. It's it's very small. Not mine.
Oh.
Money. Dinero.
I think it was her.
Huh? Oh, really? Sorry, thank you. Okay, so this is the treatment for the tetralogy of Fallot. It's called the Blalock-Taussig procedure, where they put a shunt into the baby's heart to reroute the blood. So if you look at these 4 disorders, it seems like the blood is going all over, or it's plugged somewhere, it's blocked somewhere. So what these 2 doctors did was to put a shunt. so that it's kind of like the bypass. Remember bypass in MI? When there's a clot here, we're going to put a detour. So that's what they did here in the heart. The name of the procedure is Blalak-Tausig because that's two doctors who combined their talents to do the procedure. And this is the movie that we're going to watch. Because the one who really, this idea originally didn't come from Blalak-Tausig. I'm telling you already the movie, right? It came from another person who used to work in the lab. So he's the one who actually told the doctors, you know what, this is better to do.
What's the name of the movie?
I have Something the Lord Made. It's free on YouTube. You can look it up. If we don't have time today, if we don't finish it. Yeah. So that's the name of the procedure, the Blalak-Tausig. It will be all about this procedure for the tetralogy of Fallot. Right? Simply what we need to know about tetralogy of Fallot. It's a cyanotic disorder, and it's composed of 4 disorders. So you need to know the 4. And the treatment, and the signs and symptoms are the same with anybody who's cyanotic. Difficulty breathing, difficulty circulation, they turn blue, then they do the squatting position, right? The treatment is to fix all the holes, and to fix all the backflows, and to fix all those things. So it's gonna be a heart surgery. But the main surgery that they did is called the Blalak-Tausig. So we're gonna watch a movie on that when we finish. I think I can finish by 11. So that's for the tetralogy of Fallot. For the rheumatic fever, you have to review on your own because I already taught this. And rheumatic fever. Can we go to 615 and tell me again what's the Jones criteria? Two majors, one major and 2 minors would be the criteria for Jones for the rheumatic fever. 1 major and 2 minors plus a history of strep throat. Very good. So we did that already. Let's go to the last disease, Kawasaki disease. Yeah. Why Kawasaki? Because why? It's not Suzuki or Yamaha.
Or Honda.
It was actually Dr. Kawasaki, a Japanese doctor who... Yeah. Yes. She's also called mucocutaneous lymph node syndrome. It's a leading cause of acquired cardiovascular disease in children below 5 years old. So I sit for my boards. I always ask myself, how do I remember this? Well, one, it's a weird disease. The name is Kawasaki. But I know it's acquired cardiovascular disease. But so what? What does it? How do I remember it in terms of what's happening in the heart? So I would know that there is inflammation of the blood vessels in the heart. That's it. That's the one that is my first thought process. There's inflammation of the blood vessels that could lead to aneurysms. You're right. So that's another thing that I remember definitely. But I don't think they will even ask you that. They would focus more on the signs and symptoms. How do you know it's Kawasaki disease? The peeling of the peeling of the fingertips and the strawberry tongue. Anytime we see strawberry tongue in the boards, bam, we know it's Kawasaki disease. Well, at least we have a feeling it is Kawasaki disease. So our signs and symptoms, because I said I started with inflammation, so I know there's going to be a fever. And the fever is very high. So 104. So the fever is high and they have aneurysm, so they have peeling of the fingertips and they have a strawberry tongue. That's all I need to know about Kawasaki disease. So you drop your $1,000. So our diagnosis will be ECGs, the echocardiograms. And the treatment is because it's inflammatory. What labs, by the way, will be up? ESR, white blood cells, ESR, and CRP. Right? CRP will be your C-reactive protein. I mean, it's automatic. You sit in your boards and there's inflammation. They ask for these 2 things, CRP and ESR, and then the white blood cells. So what's the treatment? Immune globulin, G, IG, IVIG. Okay? This is cardio. They have a fever. Give them aspirin. Sure, why not? Right? And then on the right side of the book, long-term low-dose aspirin. You will see that there. So I want to just, for my takeaway for the Kawasaki disease is inflammation of the blood vessels in the heart. And could lead to aneurysms in the heart also. And then they have a strawberry tongue appearing in the fingertips. And it's more inflammatory in nature, so I'm going to give aspirin because they have a fever, so I'm going to give aspirin and the antipyretics. Chapter 27. Yes?
Oh naman?